Epidural steroid injections. This is a tough treatment strategy. And besides the fact that it's outside of our scope, it is something that a lot of patients have already had or at least are considering if they're not getting well with your care. So the first thing that I consider when I have someone who wants an epidural steroid injection is if you have neurogenic claudication, that's normally due to lumbar spine stenosis, a mechanical source of compression, and these patients do not respond well to epidural. So I'll let them know anything is available to you. You know, every patient can decide what they want to do with their own care. However, the research shows that this is not a good or effective treatment strategy. Now, with that being said, when you have any kind of degenerative source of mechanical compression to a nerve, there's not a lot that we can do to prevent that. Now, there are strategies like flexion distraction, traction, manipulation that help open the intervertebral foramen, and along with exercises that can help open up that intervertebral foramen, more of your flexion-biased exercises. However, as far as long-term management, unfortunately, they have to manage it conservatively, and if that doesn't work, then you go more towards a surgical route. But there are certain cases that do respond well to epidurals. Those patients who are having an inflammatory response due to a peripheral neuropathy do respond well to epidurals, and those patients with acute disc problems that have a massive inflammatory reaction could be to a disc herniation, protrusion, where there's not mechanical compression of that nerve, but there's a massive inflammatory reaction in that area because of that disc problem. So it's something to consider for your patients. Now, risk factors, they are small. When it comes down to infections and bleeding and nicking of nerves and all those things you hear about, those complications are small, but they are there. One thing that I do want to point out to you and also hopefully to your patients is that there is an increased risk of osteoarthritis. The same as when you have an RFA, radiofrequency ablation, is that you're numbing that area. Now that person who normally has a stop sign that says, hey, John, it hurts when you walk, 20 minutes, no longer has that stop sign and no longer has that check engine light. And now they can do some more damage to that tissue. And unfortunately, there's a carrot out there that says, well, get another epidural injection. If you get another epidural injection, it's going to make you feel better. They want another one and another one and another one because these epidurals are short-lived as far as their pain relief. So keep in mind that when you get that injection, it's a window of opportunity to help you get some mechanical work done on that patient, but it is not a green light to do whatever you want, because unfortunately, while you do have numbing in that area and decreased inflammation and decreased sensitization of those nerves, unfortunately, that patient, if they just go back to their normal life, they're going to keep on doing damage that may manifest as osteoarthritis at those spinal segments. Just things to consider for your next patient considering epidural steroid injections.